Consider a female patient presenting with established rheumatoid arthritis. The inflammatory process aggressively targets specific small joints in her hands. Looking at this skeletal diagram, we see the exact high-frequency involvement pattern of the disease. The damage concentrates at the metacarpophalangeal, or MCP, joints, the proximal interphalangeal joints, and the wrists. This clinical photograph shows the macroscopic result of localized inflammation. We clearly observe significant structural swelling and dense rheumatoid nodules directly on the patient's knuckles. These severe, permanent deformations are visible to the naked eye. However, they are driven entirely by invisible cellular failures occurring deep within the joint tissue itself. To see where failure begins, consider a healthy MCP joint cross-section. Its protective capsule contains an intricate network of mechanoreceptor nerve fibers. As rheumatoid arthritis causes fluid accumulation, the capsule swells. Bending the finger stretches this tightened tissue, causing those nerve fibers to fire rapidly. The sharp pain experienced during activity is a direct mechanical response. Physical tension placed on an inflamed capsule generates the pain signal. Inside the joint, the delicate synovial lining enters a hyperproliferative phase. Cells rapidly divide, thickening into a dense mass known as the pannus. It behaves like a localized tumor, aggressively expanding into the joint space. Within the pannus, macrophages activate, releasing a stream of pro-inflammatory cytokines like TNF-alpha and interleukin-6. These signals reach the bone matrix, binding to dormant osteoclasts. This turns them into aggressive excavators that carve away the adjacent bare bone. The true danger of rheumatoid arthritis is this invisible, continuous erosion. The pannus drives irreversible structural damage, regardless of how much the surface swelling fluctuates. This creates a clinical paradox. We just established that moving a swollen joint stretches the capsule and causes pain. Why then do patients experience severe morning stiffness that actually improves after they spend an hour moving? During prolonged rest, thick inflammatory fluid slowly pools within the joint cavity. When the patient wakes and moves, the joint functions as a mechanical pump. Rhythmic flexion physically compresses the space, forcing fluid into the lymphatic vessels. The severe stiffness resolves because the overall fluid volume drops. This relief is purely a fluid dynamics problem solved by mechanical pumping, operating through a completely distinct mechanism from the capsular stretch pain. To halt the structural destruction, we use biologic disease-modifying anti-rheumatic drugs. These medications deploy precise geometric antibodies into the joint space to physically intercept the cytokine signals mid-air. Neutralizing these signals stops the cascade. Deprived of the cytokine sparks, the osteoclasts power down and detach from the bone, and the pannus ceases its rapid cellular division. While standard pain medications only temporarily mask nerve signals, biologics alter the physical course of the disease. They protect and preserve the bone matrix itself. We can map the management of this disease into 3 physiological rules. First, capsular stretch equals pain. Second, fluid drainage equals stiffness relief. Third, biologics equal halting the pannus. Mastering the microenvironment of the rheumatoid joint allows us to separate fluid dynamics from tissue destruction. By targeting the exact cellular mechanisms, we can stop the microscopic damage and prevent permanent macroscopic deformity.